During one of supervision of a resident, the resident presented a case of teenage who is currently in senior in high school, I mean in 12th grade, and the teenager were presented because she was having difficulty keeping up with the grades, and she ran away a couple of times from the school, and also was found being physically abusive towards her younger siblings. She has two younger siblings, and she endorsed that whenever the younger sibling get upset, she get really mad at them and sometimes slap at them, and parents are also aware of it. She was also reported to use marijuana here and there, and also not interested in school activity, engaged in some inappropriate behavior lately. And the other thing the resident mentioned, that even mom also endorsed, whenever one time she was mean towards a cat at home, and she did not have any remorse. And even when she say mean things, or she does mean things, she does not seem to care. She does not seem to have any remorse or shame or guilt. Resident mentioned that the patient was diagnosed with ADHD, used to take stimulant medication until middle school, and then she stopped taking it, and she was doing okay in middle school, although she was having still some difficulty getting along and having difficulty in the school, but she was able to get good grades. But since she stopped taking stimulant, her academic performance, her irritability, anger got really bad, and now she has almost failing almost all the classes. So when I asked about the impression about what diagnosis the resident was thinking, so the resident mentioned that likely conduct disorder, because patient have been really angry, irritable, abusive towards siblings, and did not have any remorse, was cruel towards animal, running away from school, and involved in inappropriate behavior, was and many times mean towards parents and other family member. And also the resident mentioned that possibly a bipolar disorder as well, and thinking of starting some mood stabilizer or some antipsychotic to address with the agitation and aggression. So when I asked the trainees, what do you think why this child has been engaging in this behavior? So the trainee paused for a second, and then she mentioned that that's interesting question, that why the patient have been engaging in all this behavior. And then she started mentioning that maybe the patient never the home environment seemed to be very chaotic, because when this my student talked to the mother, so she come across that mom was very inconsistent and also emotionally very labile, and so she thought maybe the patient is having difficulty stable home environment, and she may not have been understood correctly, especially since she was doing okay until middle school, but since the stimulant medications are away, she has been having difficulty controlling her anger, impulsivity. And she may have tried to reach out to parents or other caregivers or the teacher to get some help, but every time she might have been misunderstood or labeled or judged because of her behavior, and that may lead to poor self-esteem, uncontrolled impulsivity, getting involved in running away, because when you are not doing good in school, when you are not being accepted, I would say, in school, when you are struggling, you are trying to work hard, but because of untreated ADHD, it's just very hard to pay attention. It's very hard to sit in class. It's really hard to control your anger or impulses, and you may get engaged in substance use. You may get engaged in some of the behavior, running away, not doing academically good. and as well as and then when you start deteriorating academically, socially, parents may get harder, and instead of understanding, they focus more on the behavior. They become more more strict, and with the intention to help you, but nothing have been helping. And then and mom took the patient to a couple of therapists, and she tried, but every time she get angry, she get irritable towards therapist and counselor, and usually after 2-3 sessions she never been able to connect and stop the session. So I said, you can see that these patients have been rejecting the help. And the reason this person this patient very intimidating to the younger sibling, that the patient may have learned, until I get scared my younger siblings, I mean, there is no way they can stop bothering her, and there is no way they can stop screaming or doing things that she that may affect when she was doing homework or when she was talking to her friends. So she have learned, if she wants her siblings to not bother her, she just have to be loud, and sometimes even if it involves physical aggression, that's why she may never hesitated. And then I shared Dr. Dan Siegel, neurons that wires together mean, whenever she herself was angry or upset or did not do things socially or academically, her parents might have became angry, irritable, or physically or verbally abusive. So not doing well and plus physically abusive or yelling, screaming, hitting, just both neurons fired so many times. Now automatically, in her brain, whenever someone did a wrong thing or thing that she did not approve, she will automatically yell at them, scream at them, hit them, because both neurons were fired so many times when she was growing up, that automatically, without her realizing, her body goes into that rage, into that aggression phase. And then the resident asked, why do I think that this teenager doesn't have a remorse for all these bad acts? And I said, as a human nature, as a clinician, we always pick thing that is most disgusting, and because if who in the world can have empathy for someone who's cruel towards animal, who is mean towards the mom, who is hitting or abusing the younger siblings and not having remorse? I said, that's why that part just shake us as a core, as a clinician, and that stick to our head. Our own counter transference, our own judgment just come into play. And sometimes our brain, because of human psychology, to get attention to the things that are more disgusting, more awful, make us diagnose something based on that information, and not see what is causing that behavior. Then the resident asked, but this teenager seemed to be meeting the DSM-5 criteria of the conduct disorder. I said, definitely, yes, there are some symptoms, but the DSM-5 criteria definitely is more descriptive. But, you just met maybe 1 or 2 times. So unless, we understand what is the reason behind all this behavior, it's hard to just put a big label on this teenager because of, the information we just collected with 1 or 2 appointment. And when I asked, the resident, when I asked this question, why do you think this teenager have been displaying this behavior? And I encourage the resident to write the statement that, what she was thinking. And the resident wrote that, the patient might be misunderstood. No one ever took time to connect with the patient. Everyone just bothered her. Everyone just, telling her what to do, what not to do. And whenever she has been doing misbehavior, she was being judged, labeled, or mistreated, and then she has not been performing well in school. So school is a really unpleasant place to go. So that may that may not justify, but that may make sense for that patient to running away from school. And then when you run away from school, you are among the crowd, because you cannot tell your parents, so you are unfortunately be in the crowd, people who are, using drugs on the street. And then when you go in that crowd, you may end up, doing something that you may not realize it. And then untreated ADHD with impulsivity, hyperactivity, you are more likely to use drugs, you are more likely to engage in an inappropriate behavior, you are more likely to get into argument and being kicked out and not have good friends. And I said, all these things are explaining in a way that, yes, this is not simple ADHD, but there are so many reasons that might be explaining why this child is behaving, all this way. So I said, maybe, for now, we can have the diagnosis of ADHD. And also because of recurrent anger outbursts, and even during the session, the person was pretty angry, and over the lifetime, they have endorsed significant anger irritability. Maybe we can, diagnose with the disruptive mood dysregulation disorder. And let's utilize our lens of exploring curiosity, understanding, and connecting with this teenager before we come up with that strong diagnosis. And then when the last question I was being asked is, but if the patient get really mad because during the one of the session, because the resident have 2 sessions so far, so the last session the patient get very hostile, angry, and didn't want to listen, but the patient stayed for the whole 1 hour session. And I said, I asked resident, what were you feeling? She said, she was very angry, she was upset, she was not sure, and she saw that this person was getting angry, she did not have any remorse. So, in her mind, this is a pretty typical of the conduct disorder. And I remind resident about the countertransference. I reminded, maybe next time if that patient come, validate, you just comment on the feeling. And as for Dr. Dan Siegel, when we name it to tame it, when we name a feeling, it's easier for us to tame it. And I said many times, this teenager tried to express their feeling, but every time it was being shut down, being judged. So I said, anytime it happened, you can just remind, it seemed like you angry, upset. I'm wondering what made you that upset. I'm wondering what reminded you. I would like to know if you have any similar experience in the past that you express similar kind of anger, or I'm curious to know, what other people in your life that may have made you feel upset and what you have done. So the diagnosis was, I mentioned for now we can keep the ADHD, DMDD, and also, just in the session, just try to understand, understand this teenager as a person from early childhood till now. Try to connect and try to share these things that, you tell her that, you can see why this teenager is so upset, because, all those things, that no one ever listened to her, no one cared about her, everyone made her feel that, she is worthless, there is no point of trying, and then she has been struggling with the school academically. So you share, this understanding and see what that person is saying, and then try to connect and understand before making that diagnosis. So the bottom line, which I would like to share, with this such a long video, is, as a psychiatrist, as a psychologist, as a clinician, as a teacher, as a healthcare professional, I will encourage you to be mindful about our own countertransference, our own bias, our own human psychology, to focus on most awful thing. So especially in child psychiatry, because these diagnoses are big diagnoses. I'm not saying don't diagnose it because these are big diagnoses. I'm just saying we cannot diagnose just based on 2 or 3 meetings with these big diagnoses until we feel connect, until we understand all the factors why this child is the way this child is behaving now. I hope it has been helpful, and I appreciate listening, and please share your feedback. Thank you.